Welcome to the presentation titled Best Practices in Managing Viral Upper Respiratory Tract Infections, otherwise known as the common cold, over telemedicine. My name is Pranita Tama. I'm an associate professor of pediatrics in the Division of Infectious Diseases at Johns Hopkins. I also serve as director of the Pediatric Antibiotic Stewardship Program at Hopkins, and I see patients in the hospital, in the clinic, and over telemedicine. And I'm one of the leaders of the stewardship program, along with colleagues at NORC at the University of Chicago and Johns Hopkins University. And should you have any additional questions after the webinar, please note the safety program's email address on the slide. And we wanted to welcome all of you to the webinar. Thank you for joining us today. None of the presenters have any conflicts of interest relevant to the program. And the faculty and planners are managers for the Postgraduate Institute for Medicine, Johns Hopkins, HRQ, and NORC have nothing to disclose. And just in support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and National Opinion Research Center. Postgraduate Institute for Medicine is jointly accredited by the ACCME, ACPE, ANCC to provide continuing education for the healthcare team. And this slide describes how much credit can be assigned for participating in this live activity. So I'll let you take a moment to look this over. And successful completion of this CME activity, which includes participation in the evaluation component, enables the participant to earn up to 1 medical knowledge MOC point, up to 1 practice assessment MOC point for the American Board of Internal Medicine's MOC program, and up to 1 MOC in the American Board of Pediatrics MOC program. Okay, so let's move on to the content of this webinar. So we'll be using a clinical case-based format to address the following: how to diagnose a viral upper respiratory tract infection, or URI, or the common cold in children and adults, explain why antibiotic therapy is not useful in the management of viral URI in children or adults, describe treatment options to manage the symptoms of viral URI in the telemedicine setting in children and adults, and strategies to communicate with patients the appropriate management of viral URI in the telemedicine setting in children and adults. So as a background, it's estimated that there are about 1 billion viral URIs each year in the United States. Approximately a quarter of these episodes result in healthcare encounters. Indeed, viral URIs make up about 70% of telemedicine visits, where there are concerns for respiratory bacterial infections. So we'll review a clinical case using the 4 moments of antibiotic decision-making framework. Briefly, this framework consists of the following moments. Moment 1, is my patient an appropriate candidate for a telemedicine visit? Moment 2, does my patient have signs and symptoms indicating an infection that may require antibiotics? Is a diagnostic test needed? Moment 3, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? And moment 4, what symptomatic relief should I offer or prescribe to my patient? What should I tell my patient about the expected course and the follow-up plan? So we'll start with a case. This is an adult patient. I will note that for some future webinars that focus on viral respiratory type infections like RSV, we will go through how to conduct a virtual visit for a pediatric patient. But since this case is for an adult, we'll focus on an adult virtual physical exam and history taking. So the triage note you received mentions your next patient is a 45-year-old, generally healthy male presenting via telemedicine with 3 days of 3 days of rhinorrhea, sore throat, a mild headache, and a productive cough. The patient doesn't think he has a fever, but he's not actually sure since he doesn't have a thermometer. He's been able to drink fluid and eat, although his appetite is not as good as usual. And he has not been reporting vomiting or diarrhea, but maybe a few loose stools. He made the appointment seeking a prescription for azithromycin, as it has helped him in the past when he's had viral respiratory symptoms. So again, moment one asks, is my patient an appropriate candidate for a telemedicine visit? Because on the initial triage note provided to you, there's no mention of the patient appearing ill with high fevers, altered mental status, difficulty breathing, severe dehydration based on his report of being able to eat, drink, and generally keep fluids down without diarrhea or vomiting, or other concerning signs or symptoms. So it's reasonable for this patient to be evaluated further via telemedicine. Of course, when you actually interact with the patient, you'll be repeating these questions to confirm this is the case. And I will note that even though he didn't report fevers or any episodes of vomiting, diarrhea, even if on the triage form there may be a comment that he thinks he has a fever, he's been vomiting, that alone is not enough to say that he wouldn't be an appropriate candidate. So a little of this is the clinical judgment of if the triage form seems to indicate that there are alarming signs and symptoms, and we'll describe some of these later in this webinar. So patient history. Moment two asks, does my patient have signs and symptoms indicating an infection that may require antibiotics? The second part of moment two is a diagnostic test needed? So to appropriately address these questions, you'll have to rely on your history and physical exam. After you meet the patient virtually, and after asking the patient what's concerning him today, he states that he has a really bad cold, generally feeling very lousy. He's had a few days of runny nose. It hurts when he swallows. He's been having a mild headache and has been occasionally coughing. In the past, he notes that azithromycin has helped him, and he would like a prescription because of this important work meeting he has in 2 days. So you confirm that he's been well until about 3 days ago. He's otherwise generally healthy. His only past medical condition is that he's needed prior knee surgery. And although he doesn't have a thermometer at home, um, so you don't actually know if he has a fever or not. He doesn't think he has a fever, but he's not sure. He works at home. He says he's been able to complete his usual activities like cooking, laundry, logging into work meetings, except that he's had to keep his camera off given the need to frequently blow his nose. Okay, so on the virtual exam, you note that his mentation is appropriate. He's able to answer the questions you're asking him without difficulty, so his comprehension seems to be good. He does not appear flushed. He doesn't seem to be shivering. You ask him if he's been sweating or feeling flushed more than baseline. He says no. So most likely, based on his responses to these questions, he doesn't seem to be having any major issues with temperature instability, such as fevers or hypothermia. So it's possible he has a low-grade fever still, but certainly it doesn't seem to be extreme based on his response to questions about sweating and shivering and generally feeling very flushed. You ask him to check his heart rate by placing the tips of his index and middle finger on the inside of his wrist, just below his thumb. It's always nice to demonstrate this to the patient if they're not quite sure what you're asking them to do. You ask him to press lightly until he feels his pulse, and then count a beat for 15 seconds. Multiply that number by 4 to get your beats per minute, and you calculate that his pulse is about 80 beats per minute, so he doesn't appear to be tachycardic. You ask him to comment on whether he believes he looks paler than usual. He's not really sure. You suggest he washes his hands, and when he comes back to the camera, to refocus his camera so you can get a better look at his eyes. You ask him with his now clean hands to invert his bottom eyelid so you can see the bottom of his conjunctiva to get a sense if there's any significant pallor, significant erythema for conjunctivitis, or any other abnormalities in his eye exam. Of note, pallor can be difficult to detect by simply looking at skin color for people with darker complexions, and a more objective approach is to look at the lining of the lower eyelid. So while the camera's focused in his eyes, you ask him to look up, down, to the left, to the right. You note that his extraocular movements are intact. You also note that he doesn't have any periorbital swelling, so usually that would be, sorry, excuse the bags under my eyes, but usually those would be found under the eyes. Asymmetrical would be more concerning for infection. You also notice that there's no discharge and that the sclera of his eyes, so that's the white part, looks reasonably white. So taken together, this goes against the idea that he might have something like a viral or bacterial conjunctivitis, and we'll address this in a future presentation. You also note that he has full range of eye movements without any pain in his eye movements, the lack of erythema below his eyelids, the lack of asymmetry with one eye bulging out are all very reassuring against him having a periorbital cellulitis or an orbital abscess. And often if you see that both eyes look a little puffy or a little red, that's a lot more consistent with a typical viral infection, because we expect that to be relatively symmetric versus if we're worried about an actual bacterial infection of the eye, we do expect it to be more unilateral. Okay, so now the second part of continuing moment two's physical exam, you ask him to press on his forehead, in his cheeks, in the region close to his nose, and again, it's easier to demonstrate this. So the patient touches the parts of his face that you think would be helpful, and you note that he doesn't have tenderness, so that's reassuring. You also ask him to stand up and bend over to see if that's causing significant facial pain. He doesn't have to bend all the way, but just to see if there's a fluid level that's pushing against his face. He comments that it doesn't hurt. And these findings are all reassuring against sinusitis. We'll discuss sinusitis in more detail in a future presentation. Then you ask him to move his neck as if he's nodding yes and no, and doing this to the sides. He does this comfortably. You ask him to open his mouth widely into the camera and to use the flashlight from his cell phone to provide more light into his throat. You note that his uveal is midline. He doesn't appear to have enlarged tonsils or tonsillar exudate. His dentition is reasonably normal. You ask him to feel his cervical lymph nodes. You ask him to start in the front of his ear and then to go in a gentle circular motion, gradually making his way to right above his collarbone. And you ask him to repeat this on the other side. He says it hurts a little bit, but not very much. And he doesn't say that there's any one area or one lymph node that feels very tender compared to the rest or very enlarged compared to the rest. He just feels a few rubbery lymph nodes. So taken together, these findings make the likelihood of a bacterial head and neck infection low. More specifically, given his normal mentation, the lack of clear high fevers, the lack of nuchal rigidity because he's able to move his neck freely, bacterial meningitis is unlikely. Given his relatively normal throat exam, the fact that it's not hurting when he moves his neck, you're not seeing any obvious asymmetry or bulges from your visual exam, the likelihood of a peritonsillar abscess, a dental abscess, bacterial cervical lymphadenitis are all very likely. And with his throat exam seeming reasonably normal, the likelihood of bacterial pharyngitis is also unlikely. I will also note, as we'll discuss further in a future presentation, with bacterial pharyngitis, it's very unusual to actually have viral symptoms like cough, runny nose. It's usually more high fevers, difficulty swallowing, throat pain. This patient had mentioned that it hurts when he swallows, which is another reason you want to examine his neck carefully, just to make sure there's not any concerns for something serious like an epiglottitis, cervical lymphadenitis, or other processes that could cause pain with swallowing. So thus far, it seems like his head and neck exam is pretty reassuring. Next, you ask the patient if he would feel comfortable removing his shirt. If it's a female patient, you could request she wears a tank top or something similar, but it's always a good idea to ask the patient first if they're comfortable. If they're comfortable changing, then it's better to ask them to do this away from the camera, just so you could get a good visualization of how they're breathing. And it's important to let the patient know why you're asking them this. You should also give them the option if they're not comfortable, it's okay, because you can actually get a sense of how they're breathing without having them to take their upper clothing off. So basically what you want to look for is, as you're looking for the patient, you want to make sure they're not moving their head like obviously as they're breathing. That could be associated with difficulty having shortness of breath or increased work of breathing. You also want to make sure their nostrils are not flaring as they're speaking to you. You want to look at their upper neck muscles to make sure that they're not vibrating quickly, which is also a sign that they need additional muscles to help them breathe. You calculate that this patient's respiratory rate is about 18 breaths per minute. Again, you remind yourself he's not having difficulty speaking in full sentences. He does not appear to be wheezing or short of breath. He's able to complete his full sentences without any sort of halting end to the sentences. And then you note that he doesn't have nasal flaring, head bobbing, or increased movement of some of his upper neck muscles. So taken together, it doesn't seem that he has increased work of breathing that could be concerning for something like a bacterial pneumonia, which might warrant an in-person visit. And we will discuss pneumonia in more depth in a future presentation. You then, even though his complaint seems to be more focused on a viral upper respiratory tract infection, and that appears to be the case from your history and physical exam so far, you always want to confirm with him, just very briefly, as a review of systems, that he doesn't have any new skin findings like rashes, abdominal pain, difficulty moving any extremities, new joint pain, back pain. If he endorses any of these findings, you do want to do a more focused examination on where he has concerns, just to make sure there's not an alternative diagnosis to consider. So now, based on your history physical exam, he appears to have acute onset of rhinorrhea, sore throat, cough that started in about the last 3 days, in combination with the relatively reassuring virtual physical exam, in this case, lack of a high fever, a relatively normal heart rate, respiratory rate, mental status. This does appear to be consistent with the common cold. So let's move on now to diagnostic testing. You advise this patient that no additional diagnostic testing is necessary this time. Now, although you suggest it's plausible the patient has respiratory syncytial virus, which we will talk about in a future presentation, there's no antiviral treatment for RSV for adults who are not severely immunocompromised, as will be discussed in a future presentation. So testing for RSV in an adult is generally not necessary. An exception might be if the patient is in close contact with an infant under a year of age while symptomatic. But even if this patient was older, like 70 or 80, where there is a risk for more severe complications with RSV, given that the fact that there's no actual treatment preemptively to provide, focused testing for RSV is not necessary unless the patient really wishes to have this testing performed. Now, COVID-19 is, of course, also possible for this patient. The patient can elect to test if he's interested in learning if he has COVID-19 or if necessary for his work. Of note, since he appears to be an immunocompetent person under 65 years of age without risk factors that would put him at risk for progression to severe disease, and we'll discuss what those risk factors are in a future presentation, it would still be reasonable to not, for this particular patient, even if he had COVID, it would be reasonable to not suggest targeted treatment for COVID. So again, there's no real need to test him for COVID-19 unless the patient wants to be tested or his job requires it. And we will discuss a lot about COVID in a future presentation dedicated just to COVID. And although testing for other respiratory viruses like parainfluenza, rhinovirus are available in some places, testing is generally not considered unless the patient is severely immunocompromised or patients are critically ill. And for both of the scenarios, they'd really be likely to be referred to a facility with an inpatient department. So again, this wouldn't be the type of patient you would consider testing in the outpatient setting. And then finally, influenza is less likely given as lack of obvious high fevers. Of course, influenza is also highly seasonal, meaning that in most of the United States, we're worried about it between November and February. And a lot of the likelihood of being positive for the flu depends on the local epidemiology of where the patient lives, which can be found on the CDC website. And we will discuss influenza diagnosis management in depth in a future presentation. So overall, for the diagnostics for this patient, he's a relatively healthy adult with a viral infection. Again, it could be RSV, it could be COVID-19, but there's really no treatment to offer him for those. There would be no reason to refer him for inpatient or in-person care. So it's very appropriate to not pursue any diagnostic testing for this person. Next, let's move on to moment three. Moment three focuses on antibiotic prescription after it's established that a bacterial infection is likely. Now, in this case, the patient's symptoms are highly suggestive of a viral URI and antibiotics are not needed. This is a good opportunity to remind your patient that antibiotics are not benign, have the potential to cause more harm than good. As a reminder, there's a lot of antibiotic-associated adverse events to consider: allergic reactions, rashes, kidney injury, hepatotoxicity, seizures, gastrointestinal issues such as diarrhea, nausea, vomiting. Additionally, antibiotic use is the primary driver of antibiotic resistance, which can make future actual bacterial infections in your patients increasingly challenging to treat. The way I usually address this is that if, for example, this patient had an infection that I thought might be bacterial and I'm prescribing antibiotics, I usually focus on the toxicities associated with the drug I'm prescribing. If I'm not prescribing any antibiotics in this patient, I try to get a sense of where your patient is with concerns about antibiotic use. So, for example, this patient came requesting azithromycin. I might say something specific about antibiotic-associated toxicities with azithromycin. You could refer back to one of our previous presentations focusing on antibiotic-associated risks. So for azithromycin, for example, there has been an association with increased serious cardiac events, including sudden death, with azithromycin. So you could reassure him that even though the risk is unlikely, I would hate to prescribe something that I'm quite sure won't improve your symptoms, but could actually cause you some real harm. If this was a patient with known cirrhosis of the liver, who has inflammatory bowel disease, who has some kind of underlying idiopathic seizure disorder, for example, I might sort of focus on, antibiotics can cause X, Y, and Z symptoms that might be of more meaning to that particular patient. So I kind of decide what to say in terms of antibiotic-associated harm in relationship to where the patient expectations and past experiences might be, rather than providing this long laundry list so you don't sound like a TV commercial. In terms of resistance, I also tend not to make it sound like a global public health issue, even though it very much is that. I usually let the patient know that antibiotics can cause bacteria to become resistant, and my concern is that if you do come back with a bacterial infection, we may limit the number of antibiotics that might actually be effective against the bacteria that are causing an infection for you. So I make it more about the specific patient. Okay, so back now to moment three, talking a little bit more about communication. It's important to think about effective approaches to communicate with the diagnosis and treatment of viral URIs to patients. There's a few reasons why patients and clinicians may have different views. I'll go through the reasons and then talk about some communication strategies for each of these. So first, patients want to hear the clinician is taking their symptoms seriously. Historically, as a profession, clinicians have prescribed antibiotics as a decisive way of addressing the patient's concern about their symptoms. Second, patients may expect an antibiotic because in previous medical encounters, an antibiotic's been prescribed for the same symptoms as it was with our patient. A study from 2021 found that receipt of antibiotics for one acute upper respiratory tract infection is associated with increased likelihood of receipt of antibiotics for future acute respiratory infections in both the patients and in their spouses. And third, patients may be worried about becoming even more sick and assume an antibiotic will prevent worsening symptoms. And this is a very common reason, of course. They're also concerned that maybe they won't be able to reach a provider if their symptoms worsen. It's useful to review each of these three concerns with possible solutions. So just to give you some examples of way to handle these, for the first one where the patient wants to hear the clinician is taking their symptoms seriously, they don't feel well, they want to feel better, it's important as clinicians that we make sure to validate the patient's symptoms. We may start off with something like, I can see you're definitely feeling pretty miserable. Let's work on making you feel better. But I would definitely start with a statement like this, where you're acknowledging the patient's concerns and follow it up with something like, Unfortunately, antibiotics won't help, but here are some things that might help. And in moment 4, we'll talk about what those things might be. Another concern is that the patient may be getting conflicting messages around antibiotic prescriptions for viral URIs. Again, the patient may say, the last time I had this, you were out of town, another clinician in the group gave me an antibiotic. In the in the direct to consumer telemedicine type setting, they might say, I know this is my first time seeking care at this center, but my doctor always gives me a prescription for an antibiotic when I have this. And someone also might say something like, I've had the same thing as my child, and my doctor gave me an antibiotic, gave my child an antibiotic. Will you give me one too, or vice versa? So there's several approaches to handling this. I do think it's important to stress that, thank you for sharing that. It's important to know that we've had a lot newer evidence showing antibiotics have had more side effects than we used to think. We're becoming more and more careful about only prescribing antibiotics when we think you need them. And this might be a time you remind them about some of the common antibiotic associated adverse events that could occur. For new patients, you want to may say something like, while I can't say for certain what type of infection you've had in the past, because you obviously don't want to dismiss what they had in the past, and it's possible they might have needed antibiotics for that. You could say the good news is that this time you don't have an infection that requires antibiotics. Um, and then you might pivot to some of the alternatives you could offer them, and we'll discuss those in moment 4. Consider reminding patients that it may be coincidental that their cold symptoms got better after they started taking antibiotics by saying something like, I know that antibiotics helped you feel better in the past, um, but viral infections often last a week or so and almost always get better on their own. People usually start feeling better after about 3 days, which often coincides with when antibiotics were started. It's possible that you experience the natural and expected course of a viral infection. I kind of would pick and choose when you say something like this, because I do find that some patients may be a little more defensive, and it might be easier to say, I don't actually know what happened the last time since I wasn't involved, but for this time, I can tell you that the good news is you don't need an antibiotic. Here's why, and here's what I can offer you instead. And again, the patient might say something like, well, I have this important family commitment this weekend, or I have this important work commitment, or my child has a soccer game and I can't miss that. Consider responding, I understand you have important commitments this weekend, but antibiotics unfortunately won't make this go away faster. In fact, they unfortunately could lead to an adverse event like diarrhea, which could make it even harder for you to participate in these other obligations and just make you generally feel a lot worse. If their concern is more they're worried about spreading it to others, you certainly could stress the importance of hand washing, considering wearing a mask while they're symptomatic, as other ways to limit the spread to others. And in addition, it's always important to make it clear that they can always contact you or others in the group to address any new or worsening symptoms, so that you will be reachable if in the event things get worse. In moment 4, you'll discuss what things to look out for and when they should be calling you versus going to an emergency room, for example. So let's move on to moment 4. What symptomatic relief should I offer or prescribe to my patient? What should I tell my patient about the follow-up plan? Now, the good news is that although you decided against giving your patient an antibiotic and were able to explain why, there are treatments that can help him feel better. In this case, it's a him. So we do have documents on the HRQ website that describe these in more detail. It's not posted yet, but we will have asynchronous scripts very soon that goes through specifically if a patient asks you about vitamin C, what can you respond, or zinc, what can you respond, and so forth. But for adults like our patient and older children, so usually by older we say 13 and up, acetaminophen and NSAIDs can help relieve pain such as sore throat, sinus tenderness, that could be associated with the common cold. These medications can be given to younger children as well, and we always tell the patient to follow the instructions on the bottle. I will say that there's a lot of cough and cold medicines that contain things like acetaminophen or NSAIDs, especially combination products like Dayquil or NyQuil. So you definitely want to suggest to them that if they're taking other cough and cold medicines that include some of these painkillers like acetaminophen, which is commonly called Tylenol, or NSAIDs, for example, Motrin, Advil, that they want to make sure they're not exceeding the total recommended daily dose on the bottle. And I would say that if they're taking something like a Dayquil, NyQuil, it's probably better they just stay away from the Tylenol or the NSAIDs separately so they don't overdose themselves. We'll get to children in a second, but let's focus on adults. There are several systematic reviews that suggest over-the-counter medications could be helpful. They provide marginal benefit. Examples of these are intranasal nasal decongestants. And a common name for this might be like pseudoephedrine or Sudafed, Afrin or oxymetazoline or Afrin. And in some of the other documents associated with this presentation on the website, we go through these names. These can be helpful, but it's actually been found that combinations of antihistamine decongestant analgesics are probably the most beneficial. And this includes, again, not to sort of advertise any particular product, but products like the Dayquils, the NyQuils, that might include some kind of decongestant antihistamine plus something like an acetaminophen. In general, so the combination has been shown to be more effective than the individual products. In general, they seem to reduce cold symptoms by about a day or two and decrease the severity of the symptoms. Again, you can let them know that the benefits are marginal, so they don't have to take these medications. I will note specifically with any kind of intranasal decongestant, so these might be drops or sprays they put in their nose, they should not be used for more than 5 days because they can actually cause rebound congestion, so they're not considered safe. I will say I didn't include this on the slide, but this will be a question in the asynchronous scripts. We do comment in there about sinus washes, neti pots that patients might ask about. We include a link to a YouTube video demonstrating how to do it. We also talk about how patients can sort of make their own solution at home safely and how they would administer it. The bottom line with these type of these sinus rinses is that they do seem to relieve some of the congestion patients have should they choose to use it. We do suggest that there's the water is sterile, so either boiled water or purchased water, and we go through that in the document just to reduce any chance of the rare side effect of something like an amoebic encephalitis that has been described with the use of neti pots. Okay, let's talk a little bit about children. So again, for children of all ages, as long as you're following the age limits and the dosages on the bottles, Tylenol or Motrin, again, acetaminophen, ibuprofen, are reasonable if the child is uncomfortable. We do not suggest any cough or cold medicines for kids under the age of 6 years of age, period. So under 6 years of age, no cough and cold medicines. They have been associated with apnea, serious overdoses, and death. For kids who are 6 years to 12 years, there's a warning against it. It's generally not advised, but it can be given as long as looking at the label for the specific medication. We generally avoid it if the child is under 13 years of age, and sticking with Tylenol, Motrin. There are some other symptomatic things that can happen for children a year of age and older. So usually we say 1 year of age and older to reduce the likelihood of botulism from honey. Half a teaspoon to a teaspoon of honey every 1 to 2 hours, either taken alone or mixed in juice or milk or whatever the child likes to drink, can help with sore throats. You also could try nasal saline drops or sprays followed by bulb suction. In very young children, this has been shown to relieve congestion. And in older children too, the bulb suction part may not be necessary. But if those sprays, those regular saline sprays, So this is an exception to that decongestion spray I said, where that for 5 days I wouldn't do anymore. But if it's just nasal saline, those sprays are quite safe. Again, I hate to encourage patients to waste money on products that may or may not be helpful, especially for something that is self-limiting. I often only suggest these things if the parent asks, or when I suggest that I say, don't feel like you have to do this. These are just some options because I don't want them to feel bad if they don't have the money to afford buying these things. Um, because again, some of these things can be unnecessarily pricey. And then with things like humidifiers, cold mist humidifiers particularly, they can provide some comfort. Again, I don't encourage people buying them unless they have them. If they have them, as long as they follow the instructions on the product, they keep them clean to reduce the risk of some sort of secondary infection, it's reasonable. Warm humidifiers have not been shown to be helpful in kids or adults. And sometimes in kids, they've actually been associated with inhalational burns. So I would suggest staying away from those. Okay, so let's get back to moment 4, expectations follow-up plan. This is, of course, very important. And this you should discuss with every patient you see with what you believe to be a common cold. When should they return for medical care? First, I always let them know that it's common for the nasal discharge to change color over the next several days. Whether it's yellow, whether it's green, whether it's clear, it kind of doesn't matter. It doesn't mean something is worsening. The cough as well might last several weeks. I think for all of us who've had viral syndromes, sometimes there's that lingering annoying cough. I would always let them know that that might continue. Unfortunately, we just have to let it run its course. There's nothing that can really help. Sometimes lozenges help. I will note for younger pediatric patients, unless the parent feels the child's of a reasonable age, I would say not less than 5 years of age, it's probably better to avoid them. But again, it's important to let them know some symptoms will linger, but they should gradually start to feel better within a few days. But give them advice for when to return. This is very important. If they have a high fever above 102, confusion, difficulty breathing, difficulty swallowing, severe headaches, pain in the head or forehead, face or forehead, severe fatigue, rashes, or the symptoms are not improving after 10 days, they really should be seen at the in-person setting. They can decide whether it makes sense to see their primary care doctor in emergency department. But if they feel ill in any way, confused, aren't breathing properly, I would say it absolutely should be an emergency department rather than an appointment, simply because appointments can sometimes take time. So anything at all that sounds concerning, any of these kinds of symptoms, they definitely need to be seen for an inpatient visit. So to summarize, viral URIs are common in the telemedicine setting. If a careful history physical exam don't suggest a bacterial infection, no antibiotics are necessary. And it's good to remind patients antibiotics can cause more harm than benefit. I do think it's important to come up with a few communication strategies, 2 to 3 sorts of ways of approaching this that you feel comfortable saying that you can remember. It's hard to remember a laundry list of possible responses, but if you think about the few strategies that you feel are palatable to you, it's good to sort of let your patient know that you hear them, you see that they're not feeling well, pivot to why you're not suggesting an antibiotic, the harm they can cause, and what some of the alternative approaches might be. And definitely, again, a discussion to when to return to medical care is always necessary. So the next several steps are logistics. This is information on the project website, how to look at upcoming webinars, office hours. Again, the 5 days after this presentation, you'll see the live recording of this webinar, as well as slides and a script. There will be other documents like a one-pager that summarizes some quick facts for you from this webinar. There's also some patient portal scripts that's not there yet, but will be there soon, where I review some of the guidance on vitamin C and zinc. Basically, the bottom line, if you're curious, vitamin C has been shown to reduce the duration of your URI symptoms and the severity by about a day or two. So there's some benefit with minimal risk. So it is a safe option if your patient would like to use it. We include the dosing in the document, which is at least 200 milligrams a day while symptoms last. It hasn't been shown to prevent colds, so I wouldn't suggest that taking it every day. I mean, it's not harmful, but in terms of if the goal is to prevent a cold, it hasn't been shown to be helpful. Zinc, on the other hand, also has been shown to reduce symptoms, but it can cause a terrible taste in the mouth, and sometimes with Zicam, I think that's the name of it, which is an inhaled zinc formulation, it can actually cause permanent loss of smell. So we really discourage against zinc products that people inhale. By mouth, if they want to take it, they can, but I personally think vitamin C is a little more palatable. But anyway, I'll kind of move on here. Please remember to check in with your implementation advisor, as well as submitting your MOSOPS data. And I'll defer to the NORC team after I finish for any additional information in this regard. So thank you very much for the questions.